If y'all can mute for now, by the way, as we get going. If you have questions as I'm going along, feel free to put those in the chat. I do have that up on my view. Or if it seems like I continue to move along obliviously, you can unmute. So in the context of the presentation that I have planned for today, and that I'll be doing later in the month, going to be going a bit into some general things that I may move through a little more quickly here, because I think a lot of the members of this audience are familiar with some of the general definitions around misuse, at-risk use, and use disorder, but others may not be. And I'll be talking a little bit about particular approaches around alcohol withdrawal, risk assessment and management of alcohol use disorder, particularly the population of older adults, and talk a little bit about sort of how risk factors and presentation and management may differ a little bit in the setting of the common misuse situations and use disorder in older adults. And so this is becoming an issue of greater prevalence and importance as the US population continues to age. Baby boomers began turning 65 in 2011, and they're often carrying substance use later into life than we saw in earlier cohorts. And substance use disorders are likely, in part, as a function, more common. There's sort of more common lifetime experience with illicit substance use, and substance use disorders themselves, according to population-based surveys like the National Survey on Drug Use and Health, tell us that substance use disorders are increasing quite dramatically in this population over the last 20 years, and some have indicated it may be one of the fastest growing sets of health problems in the United States. And as I think some of you out there in practice may have already figured, it's something that we may be missing more in this population due to sort of implicit bias around what we expect might be happening among the population of older adults. So something important to have on radar because of that, but also, as I'll be getting into later, the population of older adults are much more likely to experience substance-related harms at lower levels of use. And so our approach may need to be a little different. As you all also likely know, problematic or risky substance use can complicate the management of a number of other conditions with whom older adults may be dealing, and may create risk in terms of interaction with medications and things. So there are a number of considerations particular to the population of older adults that you know, we may not be thinking about quite as much in the younger folks that we're seeing in some of our practice environments more commonly with these issues. So again, I do want to touch on a couple of definitions briefly and overarching concepts related to the diagnosis of use disorders, but may move more quickly through that for this audience. So feel free to, you know, stop me. We need to talk a little bit about epidemiology, and then I'll get a little bit into the medical management of some of the common issues that come up in the population of older adults around substance misuse, with alcohol, of course, being more and increasingly common in this population. And then one of the next most common sets of issues are around prescribed medications, including opioids, and even more commonly, perhaps sedative hypnotics. So I'll talk a little bit about those things. So a number of you, I recognize a lot of names, so I'm sure this is something that a lot of you have already seen before. But just to reiterate, sort of the diagnostic criteria around use disorder, sometimes used interchangeably with the term addiction, but as many know, the term addiction doesn't appear in the Diagnostic and Statistical Manual of Mental Disorders. And the stem of the definition is that an individual is engaging in maladaptive use that is resulting in repetitive consequences in 2 or more of these areas over the course of the last year, with these first 2, tolerance and withdrawal, being the manifestations of physical dependence that are, there's sort of a caveat with those that you may be aware of. If someone develops tolerance to higher doses of a prescribed medication, but they're taking it for the appropriate indication and they're adherent to its use, then that criterion doesn't count. Similarly, if they miss a dose and begin experiencing withdrawal but have been otherwise adherent and their use is not dysfunctional, that criterion also does not count. And we're looking more for these other criteria indicating that an individual is engaging in compulsive use or that they've lost control of their use of that substance. So important to have an eye to language in this area, and I think we've emphasized that in this forum a number of times. We want to make sure that we're applying clinical language with precision and diagnostic accuracy to avoid stigma and inappropriate diagnosis, and just also should know about some terms that don't really have diagnostic precision anymore, and so hence really aren't particularly communicative and maybe stigmatizing, with a good example there being the term abuse of a substance. And abuse did used to be a substance-related diagnosis in the 4th edition of the DSM, but is no longer. So I generally encourage learners I work with to just avoid using that term altogether in the context of medical documentation. Dependence may still have some utility when we're talking about, physical dependence, but is really no longer something that we should be thinking about as, substance dependence interchangeable with addiction, something along those lines. And if we're documenting and talking about a patient who may be engaging in substance use that we're concerned about but falls short of those definitions around a use disorder or at-risk alcohol use that I'll be talking about a little bit, then misuse is a fine term to use, doesn't appear in the DSM, also lacks some precision, but perhaps less stigmatizing than using something like abuse, for example. So as we're looking to identify either problematic use, use that may put someone at risk, or use disorder, something that may sort of raise flags for us or lower our threshold for more detailed assessment, maybe risk factors that are present. And these are a few that we know about in the literature for all comers of adult age. But there are a few here that seem to be particularly strongly associated with the development of a use disorder in older adults. Anyone want to throw up in the chat guesses as to which of these risk factors seem to be particularly prevalent among older adults with use disorders? Depression, social isolation, chronic pain. Guess it. Yeah. Bereavement. Yeah, so good. I think you caught a number of those. So the bereavement, the chronic pain, less so. Being a caregiver and spiritual practice, I found interesting as I was digging into this, which hasn't been particularly strongly associated in younger populations, but may have perhaps, one might theorize, something more to do around isolation, social network, things like that. But these are some of the things that we know are more strongly associated with risky and problem substance use in older individuals. And these are some of the things we might look for, or events that might occur, or presentations that should give us pause and lead us to be thinking a little bit about riskier problem substance use being on a differential diagnosis of potential contributors to the issues. So falls and injury, impaired self-care, nutrition, incontinence. If they seem to have had a particularly strong response to medication initiation, unexplained seizures, dizziness, blackouts, a number of cognitive or psychiatric presentations that may be more likely accompanied by problematic substance use, disorientation, impaired decision-making, anxiety, depression, trouble with insomnia, isolation may confer risk for the development of a use disorder, but it also may be manifestation of a use disorder as well. So all things to sort of have in mind as potential triggers for taking a deeper dive into a person's substance use pattern. So in the setting of alcohol, I think considerations around alcohol for older adults become fairly interesting when you consider that the vast majority of harms attributable to alcohol in the population at large really are due to patterns of alcohol consumption that fall short of a use disorder and occur much more frequently in the setting of, say, a binge episode of use. And that's particularly true for older adults, where patterns that fall well short of a use disorder may be creating health risks or adverse health events. And when we're digging into this, the current guidelines around alcohol consumption put out by the National Institute Alcohol Abuse and Alcoholism, or the NIAAA, are based on these standards around what a standard drink is considered, that you see pictures of up there. And the guideline, again, is made up of basically two components: sort of overall weekly consumption in terms of standard drinks, and then a number of drinks that constitute a binge episode, meaning that that's the number of standard drinks we would expect that would lead someone to exceed the legal limit or blood alcohol concentration of 0.08. And so in the setting of older adults, many learners that I work with are aware that the recommendation for standard drinks for men is a total of 14 or less in a week, and 4 or less on a particular occasion, but many aren't aware that that actually changes after men reach the age of 65, and that then the recommendation mirror those for women, where the recommendation is 7 or less standard drinks in a week, and the fourth drink comprising a binge episode or a level where they may achieve that legal limit or above that legal limit. And that's where we also know there's greater risk for falls and accidental injury, greater risk for being victimized in terms of assault in younger populations, greater likelihood of committing assault. So these are the guidelines, and that's the wrinkle by way of the guideline is men in particular age. And many I work with may have seen this pyramid before, and I think it's fairly intuitive, and it's sort of a framework for thinking about the different potential levels around an alcohol use pattern, moving from the lowest risk pattern being abstinence to drinking within those recommended limits I just described as low risk use, then exceeding those recommended limits but not meeting use disorder criteria, being potentially harmful or high risk use, and then with increasing consumption and experiencing of consequences, moving into that use disorder category. Again, with the consequences being important, we shouldn't exclusively being look at an amount consumed and identifying that as a use disorder. That really is the key part of the definition, is that the use is maladaptive and is resulting in those consequences due to that use. Because, and I talk about this with our fellows all the time, kind of interesting to me is that only about 10% of individuals that are exceeding those recommended limits in population-based studies actually meet those criteria for a use disorder, meaning that oftentimes formal structured treatment may not be as much what they need, but they probably need some other sort of intervention, be it brief, be it considerations around pharmacotherapy. But when we're talking about the population of older adults, I think a question becomes, at what level is the use really low risk, right? I mean, again, with binges, obviously there's that risk for falls, accidental injury, other things, but recent data are telling us that even with these lower levels of really regular consumption, there may be risk for longer term health issues. There was one of the most widely cited studies of 2017 in BMJ, longitudinal cohort study indicating that even within those recommended limits, but with daily consumption, there were associations with statistically significant associations with some impairment in cognition, with that being primarily lexical fluency or word finding. And again, that was statistically significant. The extent to which we can extrapolate that to mean that it's functionally or clinically significant remains an empirical question that hasn't been answered, but may lead us to take a pause and think about how we're counseling around alcohol use as people age. So I already made mention of the fact that risky and problem substance use, and when I say problem substance use, I'm really referring to use disorder, that these are present at higher rates in the current population of older adults than they have been in the past. And when it comes to alcohol, that's been particularly true over the last 20 years of female older adults, where abstinence rates have declined, current drinking has been going up, and binge drinking has been going up as well. And why might we be a little more concerned about that? Because in this literature, it also appears that with those higher levels of drinking, women may be more likely to experience some of the longer term consequences, such as liver disease or other gastrointestinal complications. So as I mentioned, something to have an eye out for if older adults are presenting with issues like that and be assessing around alcohol use. Another consideration in this area around older adults is, whether current recommended screens function as well in the population. And the CAGE clearly is not a horribly effective instrument in the population of older adults. There is a screen, the masked geriatric version here, that seems to do particularly well so far as sensitivity goes. It's a little bit more cumbersome to administer. It's 24 items, so may not be horribly practical for systems to be thinking about doing that in their emergency departments, hospitals, or their primary care clinics. But I think it just illustrates that we may need to have kind of an eye to different sorts of screening depending on the population, as we do for adolescents and for women of childbearing age with the CRAFT and the 4Ps and the TWEAK in those settings respectively. But the one that we use here and that's used many other places is the shortened version of the audit, known as the AUDIT-C, where the full audit is 10 questions, getting into frequency and amount of consumption in the course of the first 3 questions, and then the remaining 7 being exploration around consequences related to that pattern of alcohol use. So the AUDIT-C is just those first 3 questions asking about quantity and frequency of consumption. And in the setting of older adults, You know, if you're doing screening and you want to make it even snappier, it's really the binge questions that seem to bear out by way of having the greatest precision around sensitivity, specificity for future alcohol-related harms in this setting. And these are the AUDIT-C questions for those who haven't seen them before. So it's the 3 questions. And it's on a Likert scale from 0 to 4 for each of these items. So it can potentially generate a score anywhere from 0 to 12. Where in younger populations, scores of 8 and above are pretty strongly associated with there being an alcohol use disorder present, in the range of 5 to 8 being more likely that pattern of at-risk use or exceeding recommended limits without meeting criteria for a use disorder, where brief interventions may be effective, which I'll be talking about briefly in just a minute. 3 to 5, where even lower level interventions may be helpful. For example, it's simply providing information around the recommended limits and developing strategies for those. And then this again, the highlighting here is just to emphasize that point that the binge question of the AUDIT-C looks to be the most sensitive around detecting alcohol misuse and future alcohol-related risk among older adults. And I already went over this bit. And I already alluded to this, but it's something I always include when talking to audiences like folks preparing for a geriatric board, just to emphasize that there are a number of conditions you will be seeing every day that may be complicated by alcohol use, be it you know, at-risk use disorder, or in some cases, maybe even that low-risk use pattern. So it's important to have an eye to screening and potentially assessing in more detail if these issues are arising, to prevent further complications down the road from them. And what's a brief intervention? I alluded to this just a little bit ago and indicated that this is an effective strategy to deliver in primary care settings and in emergency department settings, and scientifically rigorous studies over many years and with many hundreds of subjects have told us that. And it can be a fairly time-limited intervention, 2, perhaps even 1, actually, of 4 sessions of 5 to 15 minutes, where we engage in discussion around the use pattern, getting specific about rationale for concern around it, and engaging in some shared decision-making through motivational interviewing strategies to arrive at plans for positive behavior change, where a goal in this setting is most often framed as use reduction. And it is effective in doing so. And that, again, that population engaging in at-risk use. Brief interventions seem not to be as effective in individuals who have a frank alcohol use disorder, though that's been studied back in the days of the DSM-4, where you know, we didn't have sort of 2 criteria landing someone on actual use disorder. So whether individuals in that mild use disorder spectrum might respond to brief intervention is still also a question, and one that remains to be investigated. So if folks aren't accepting of higher levels of care, still perfectly reasonable to engage in this kind of strategy as a first step. So if someone does appear to have an alcohol use disorder, or maybe simply a physical dependence, or there might be concern for physical dependence and withdrawal, that's sort of a first stage in our thinking and our plans around management. Are, you know, what is the risk presented by a current possible level of physical dependence, and is this something that could perhaps be managed on an outpatient basis, or should the individual be in the controlled environment of hospital or a dedicated detoxification facility to ensure that this can be done safely? And I've put a few things on this slide that can be helpful in getting some sense, albeit imperfect, of risk for more complicated withdrawal states, such as delirium, alcohol withdrawal delirium, or delirium tremens, seizure, or hallucinoses. And individuals that have gone through those things before are at greater risk to do so again in the setting of dramatic reduction or abstinence in terms of their use. That they've had a seizure, delirium tremens previously, they're at greater risk to have it again. And if a patient endorses having had DTs or delirium tremens, I think it's important to emphasize that it's a good idea to clarify what they mean by that, because I've had a number of patients respond in the affirmative, say, oh yes, I've had DTs before, but when I look to clarify, they characterize that as being waking up in the morning and feeling shaky and needing alcohol to calm that down, which obviously is not delirium tremens, which is characterized by delirium and disorientation, and sometimes even combativeness, and an increase in mortality, being at around 15% for untreated delirium tremens. If available, recent serum electrolytes can be helpful if they're within normal limits. That's reassuring. Medical comorbidities may come along with greater risk for more complicated alcohol withdrawal. A mean cell volume above 100 may also be associated with greater risk for withdrawal. I tend to see this less in older populations, but it happens. If an individual is able to attain a blood alcohol level of 300 milligrams per deciliter or 0.3 grams per liter, then that indicates a fairly high level of tolerance and has been associated with greater risk for the development of more complicated withdrawal states as well. We also, if we're considering an outpatient treatment plan, want to have an eye to what sort of support they have in the home, so that if, despite our outpatient plan, their withdrawal symptoms are escalating, there's someone around that can have an eye to that and get them to an appropriate level of care, the emergency department, if it's still becoming an increasing problem despite our management strategies. One thing to note is typically among younger individuals, we generally expect withdrawal from alcohol to present with those autonomic signs and symptoms earlier, the anxiety, the tremulousness, tachycardia, and hypertension. But in older adults, it can present quite early with confusion, and may even present with confusion prior to there being an overt or discernible tremor, or there may have been a baseline tremor that may have confused the assessment there. And in older adults that do go into those more complicated withdrawal states, may go through it for a longer duration, and we may need to anticipate more active management for longer periods of time if they're hospitalized for that. So we're thinking about an outpatient management plan for alcohol withdrawal. These are some examples of potential regimens. Gabapentin and lorazepam have been compared head-to-head for alcohol withdrawal, and the scoring system for that withdrawal severity, the CWA scale, has been indistinguishable between the gabapentin and lorazepam arms in those studies. So on an outpatient basis, I've really pretty much turned to that, just given its much broader therapeutic window, lower risk for respiratory depression, particularly when we're talking about the population of older adults. So I'd really encourage you to think about that. On the flip side, there may be greater likelihood in older adults that gabapentin will have the adverse effects that we'll sometimes see, including sedation or fogginess, and may confer some risk for fall as well. And so that's also, again, where it's important to have an eye to getting a sense of their environment in terms of risk for that and the support that's going to be present keep an eye on them. But so I may start with lower doses in this population than I would in younger, 200, 300 milligrams 3 times a day, and ensuring tolerance before titrating up on day 2, if that goes well. And ideally still for purposes of the withdrawal management piece, getting to what's been established in randomized controlled trials as a therapeutic range between 1,200 and 2,400 milligrams daily. May not in the population of older adults be getting as close to that 2,400 milligrams, but maybe targeting sort of the lower end of this range. You know, and I don't know that even crossing out chlordiazepoxide is particularly pertinent. I mean, unless someone has a frank identified gabapentin allergy, particularly in the population of older adults. If I'm feeling like, oh my gosh, I'm worried about this person, maybe I should use a benzodiazepine, then the next thing I say to myself then is, well, then why, Randy, aren't you thinking about sending them to the hospital? So, but the reason I have chlordiazepoxide crossed out here as opposed to lorazepam is chlordiazepoxide, much longer half-life, greater number of active intermediate metabolites, so conferring greater risk for respiratory depression and sedation. So if for some reason this is happening outpatient and a benzodiazepine is used, then lorazepam would really be the agent, since it only undergoes single-step glucuronidation in the liver prior to elimination and doesn't come with those active intermediate metabolites. So far as management by way of use disorder generally, I won't belabor the point around behavioral treatment. I put this up simply to emphasize that that is, you know, a cornerstone of management. Also to emphasize that managing the withdrawal isn't treatment for the use disorder. It's really a separate set of considerations. And these are some of the levels of care that can be considered, and going into the nuts and bolts of assessment to suss that out is a little bit beyond the scope of our time and the content today. But these are the kinds of resources to which we may consider referring folks for their behavioral management. But I do want to spend a little time around the pharmacotherapy, because this is something that can be done in the variety of settings, including hospital, emergency department, primary care, and can be done effectively. And in some studies as effectively as specialist care, depending in some part on the severity of the use disorder. The one thing I emphasize here, the pharmacotherapies that are FDA approved for this indication are the Naltrexone, Acamprosate, and disulfiram, where the others are not FDA approved for that indication. It can be used off-label in selected patients, as there are data from scientifically rigorous studies to support that. I would say, though, that in the population of older adults, we'd probably consider disulfiram, baclofen, and topiramate less due to risks associated with the adverse effects that can go along with those medications, including sudden cardiac death in the setting of disulfiram, physical dependence, and a withdrawal that looks a lot like alcohol withdrawal and benzodiazepines. For baclofen, topiramate, there are cautions around renal impairment, bleeding risk, as well as potential exacerbation of depression. So perhaps more a consideration than disulfiram or baclofen, but the other options are probably preferable. And naltrexone, fairly straightforward to use, is an opioid antagonist. So of course, the primary contraindication would be the presence of physical opioid dependence, where the naltrexone would precipitate opioid withdrawal. It is hepatically metabolized, so there are cautions around its use if abnormalities in liver function are particularly dramatic. The transaminases here, the AST, ALT, if they're greater than 3 to 5 times the upper limit of normal, there's caution advised. Though if this has been assessed and there's a fair bit of confidence that that elevation is due to the alcohol consumption, and they're dedicated to a plan around positive behavior change, use reduction, or abstinence, then the naltrexone is probably lower risk than the alcohol. But that is a conversation and one to go into some detail around with patients. The typical dosing regimen, 50 milligrams daily. There is also something patients may ask you about called the Sinclair method, where they're advised simply to take the naltrexone only when they plan to drink, and then they don't get the positive reinforcing effects of alcohol on each of those occasions, and the desire to drink gradually extinguishes over time with that behavior repeated. And then you're also likely aware that there's a monthly injectable formulation known as Withdrawal that also has the FDA approval for that indication. Acamprosate, we don't know with precision how it works to facilitate abstinence or use reduction, but seems to involve something around GABA modulation or reestablishing balance between GABA and glutamate, GABA being the primary sort of calming CNS neurotransmitter, glutamate being activating, and those being out of balance in the setting of chronic heavy alcohol consumption where the GABA system has been downregulated, and then the glutamate system acts relatively unopposed, creating the anxiety and craving. But acamprosate may help facilitate healing along those lines. Very safe medication, tens of millions of prescriptions worldwide, not a single serious adverse event attributable to acamprosate. Cautions around impaired renal function that you can see there, but a fairly strange regimen. 333 milligrams TID for 3 to 5 days, 666 milligrams TID thereafter. That's the regimen studied with a large enough number of subjects that they landed on the FDA approval. There were studies of 1 gram twice daily where there was some effect. So I generally tend to start with the FDA approved regimen, but if people are experiencing some benefit, then but they're struggling to take that third daily dose, as most people do with a TID regimen, then I'll advise that they move to twice daily or 999 milligrams TID. So I'm gonna sally forth into benzodiazepines and opioids. These are some of the more common substances conferring risk in older adults. And the thing that's interesting when we think about these situations, so far as sedatives and opioids, is there's some real differences with how this looks in the younger population. The misuse or the development of use disorder, physical dependence, is more frequently inadvertent. The source is the vast majority of the time prescriber rather than an illicit source, likely associated with the fact that they're having more clinic contact, they're having more pain-related visits, and that's sort of leading to potential risks for that kind of situation. This is another situation, though, where short of even a binge on these substances or development of a use disorder, there may be some risk due to drug interactions in the setting of polypharmacy, reductions in volume of distribution and metabolism, and they're conferring increased risk for consequences such as falls, motor vehicle accidents, and need for emergency department care. There is not yet a universal screening recommendation for younger individuals or older adults around substance use outside of alcohol, with the U.S. Preventive Services Task Force indicating that current evidence doesn't appear to tell us that early screening is particularly effective in terms of reducing risk for progression to more severe issues. There are exceptions in the setting of pregnancy, women of childbearing age, and the setting of chronic pain management. But there has been some recent work with older adult samples with the severity of dependence scale that look potentially promising. So particularly if it's an individual that has been prescribed those substances with some frequency in the past, may be reasonable to be thinking about this level of screen. And as you can see, the AUC under the receiver operating curve quite favorable for this instrument with pretty reasonable sensitivity, specificity, as well as positive and negative predictive value. Already alluded to this, misuse of opioids in the population, much more commonly prescription than illicit. And as with other prescription substances, unintentional misuse and unintentionally developing dependence is more common than we see in younger populations, and the source is most typically the prescriber. So just drawing attention to that just by way of having an eye to counseling. So if patients are receiving a prescription like this, counseling around appropriate storage and environment, getting a best sense of their function, handling of medications, or if they might need assistance with that. And storage is also an important concern, as in younger individuals, adolescents, young adults, one of the most common sources of prescription-controlled substances is a family member. And so encourage patients receiving prescriptions like this not to advertise the fact that they're on them, and to store them ideally in a locked and/or hidden location. So in terms of considering opioids as part of a pain management plan in older adults, there are some considerations. For older adults where hepatic and/or renal impairment may be issues, opioids may turn out for selected patients to be safer than Tylenol or nonsteroidal anti-inflammatories, and may provide them relief and improve function, but important to have an eye to some particular issues given associated risk. Longer acting agents more likely to result in overdose, respiratory depression. So want to start with shorter acting agents if it appears they're indicated. And don't lull yourself into a false sense of security about tramadol and relatives. They are still opioids. Still confer risk for fall and fracture, and actually are more strongly associated with delirium than the more traditional opioids. Recent recommendations from the American Geriatric Society indicate that we should be thinking perhaps about buprenorphine as a potential strategy rather than your more typical opioids early. Less sedation, and there generally doesn't seem to be an increase in half-life with aging, unlike some of the other opioids. And the recommendation is generally against methadone in the age group, with some exception due to QT prolongation and cardiac risk. Another issue we're touching on here is the issue around tapering. A number of older adults that some of you may have in your practice may have been on opioids for a long time, maybe prior to meeting you, or maybe there's an event where you're worried about their current daily dose, but would just have an eye to, controlled tapers, and really supporting patients through that. We know that more rapid tapers have been associated not only with exacerbation and pain and associated mental health conditions, but also have actually been associated with greater likelihood of suicide. So certainly want to have an eye to reducing higher doses of opioids, 90 morphine milligram equivalents or greater in the CDC guidelines. But there may be selected patients where their function and their pain levels are improved at levels approaching that. So it shouldn't be viewed, and the CDC has said, as much as necessarily a hard ceiling, though we do want to have that for a goal in most situations. Would anticipate with tapering of higher dose opioids that opioid withdrawal symptoms may emerge, particularly during the last half of the taper. and so may need to consider adding on medications to provide relief from those symptoms, and probably starting at lower doses than we typically do in younger individuals when we're talking about these alpha agonist agents such as clonidine or lofexidine, since those also cause some risk for hypotension or sedation and fall risk. So into that. Sorry that I'm speeding up, but I see that we're getting close to the end of the hour, but want to close with a little bit around benzodiazepines and having those. It's the most common psychiatric medication among all older adults, and 15 to 32% of individuals over 65 have received a prescription for benzodiazepines in the last year for indications such as insomnia, anxiety. Older adults do have greater sensitivity to potential adverse effects of the medications due to reduced lean body mass and longer duration of action due to impaired metabolism. So something to have an eye to. And physical dependence to benzodiazepines can develop even within 2 weeks of continuous use. So, and that can be a difficult situation by way of tapering people off of them. And these are some of the complications that can develop, particularly in the population of older adults: the physical dependence, risk for falls, fractures, 50% absolute risk increase for that issue, and also cognitive impairment. And this seems to be something that there isn't necessarily adjustment to over time. So where opioids tolerance seems to develop and cognitive impairment may be less, that seems to be less the case with benzodiazepines. And the literature I look to for that, in part at least, are driving simulation studies, where with longer term stable doses of opioids, reaction time and judgment among those on longer term opioids is indistinguishable from normals, where that's not the case, even with longer term prescribing for benzodiazepines. So the American Geriatric Society recent guidelines generally indicate that we shouldn't be prescribing benzodiazepines longer term, and specifically should have an eye to it in individuals that have had a history of falls, individuals that are on a greater number of medications, particularly psychiatric medications, and should be, in their recent guidelines, they added non-benzodiazepines, benzo receptor agonists, or the Z drugs, is falling squarely into this category by way of considerations as well. Many have likely worked with patients and trying to taper benzodiazepines, and this can be a real challenge for folks. Colleagues I talk to will frequently agree when I say, man, sometimes it feels even more difficult than tapering opioids. And so really, going slowly, supporting folks through this is important. And I just put up being flexible about the taper rate, taking a pause if you need to, as long as there are still plans for forward progress. And I just put up this example from an article just by way of illustrating how prolonged successful tapers may need to be going on. In this case, 22 weeks, and requiring a little bit of, creativity by way of the tracking. So just have an eye to that. So adjunctive treatments in the setting of benzodiazepine tapers haven't borne out particularly well, though there is some evidence for the addition of lower doses of doxepin to assist with the insomnia that can come around during such a taper, but avoiding the Z drugs, anxiety, cognitive behavioral therapy has been a particular modality studied in the setting of benzodiazepines and their taper. Tricyclic antidepressants really haven't borne out as being effective, and also confer risk due to their anticholinergic activity. And the SSRIs, you see some of the concerns here as well. So that was really what I had today. I'm sorry that I got so close to the end of our hour by way of looking to questions, just putting up some resources by way of the Access Center to call. There'll be an addiction medicine physician on call 8 to 5 during the weekdays. So if issues in this population or others just around substance use come up, and you'd like to talk to someone with addiction medicine training to run ideas by, feel free to make use of that resource. And we continue to have our ECHO series of teleeducational sessions on the third Friday of each month at 12:15, where we go over some cases and discuss them and go through some didactic content related to substance use disorders and comorbid conditions as well. Also want to plug an upcoming session. Some may have heard that there's been modifications to accessing a data waiver, making providers eligible to prescribe buprenorphine out of the office for use disorder. And so we've set up some of these quick lunch and learns just to give people a little more orientation to what that statement really means, and also give people information about what this sort of looks like in clinical practice, and provide a forum for discussion for those of you that might be thinking a little more about moving into that practice with that recent announcement. So, all right. I will stop there so we have time to field a couple questions before the end of our hour, and leave up some of our conclusions, and I'll leave my email up there in case you want to contact me afterwards with questions about the presentation, or again, if you have questions about some of the research that's going on in referring folks to us for possible participation.